All right, shoulder pillows. Shoulder pillows, can I get those shoulder pillows? So what's great about doing this exercise with you guys is because you guys don't have your linens here, which means you have no choice but to work through the clothes.
We could go get them.
No, that defeats the exercise. All right, so getting her on the table, it looks like, you sleep on your left side?
Yes, more. Left or back?
So can we see how it is that we can actually tell that she sleeps on her left side?
Oh, her right side's elevated.
Not just elevated, but if you look, the contours of her left side versus her left side structures are more in line than her right side structures. There's more contour happening on that right side, right? Versus you can see the structures on her left side all kind of line up in a straight line. So that tells me they are used to being lined up in a straight line. All right, so just basing it off of my initial sort of palpation assessment, I can feel. Yeah.
It's supposed to be in a straight line, right?
The side she sleeps on.
The contour, but like neutral position is supposed to be straight.
Yes, that's if you're looking at both sides equally. But if you take a look, this side here, there's like less deviation versus you can see almost the contours of the outer portion of her body here.
Yeah, I get that part. I was just asking if we want to make that side look like this size.
Technically, that's not my goal. That's just kind of, that's my initial which side is challenged in what way. And just based off of her sleeping, it tells me she's used to being overstretched on this side here. All right, so that was just kind of like, what can I expect to feel in the tissues based off of what I'm currently seeing? So as I go in and actually try and bring the two sides down, she's actually very hiked on this side here, probably pillow situation. As I'm working my way down and into the hips, so she said, she confirmed she sleeps more on the left side. When I actually walk down the back into the hips and I try that sort of back and forth into the top of the hips, just to see what the tissues are feeling like, the left side, it travels, versus her right side is approximated, like it's actually stuck, elevated. Now when you think about how people are positioned when they're laying down on their side, yes, we're not getting into that stuff just yet. So when we lay down on our side, the midsection drops towards the mattress, right? So when people end up sleeping, you'll actually notice that the side they're laying on is actually pried away. So what you'll notice is when you get to the lumbosacral junction of an individual who sleeps on their sides, the one side is going to be overstretched and it's going to feel like the sacrum and the hips wants to deviate this way, like that, right? So, as I was talking with you guys in the earlier terms, yes, we want to rebalance, we want to elongate the approximated side and approximate the elongated side, but thinking about how things are being challenged deeper than just the superficial structures, you can actually feel how the lumbosacral junction is also being challenged like this, which means that I would like to try and release these structures on the approximated side, and we're going to be trying to actually fold this corner over. All right? So instead of it being positioned like this, we're actually going to try and challenge it the opposite way. Kind of, sort of? Okay. Now, before I go in and challenge that, though, I want to see how it feels throughout the rest of the chain. Okay? So we know this is the overstretched side. We know that this is the approximated side. So I'm just going to go ahead and see how the approximated side feels compared to her overstretched side. Good. Tension down that lateral chain. That's not unusual. And there is less tension down this lateral chain. Now, how many of you have had a patient come into the treatment room and they say, my IT band on one side super, super tight? Or just the one side? Only Ryan's had that patient? Yeah. Okay, Ryan, you're special.
No.
Well, occasionally you'll have a patient that comes into the treatment room who says, my one side is super, super tight. Very often, that is their top leg. Because when they're laying on their side, well, actually when you're standing, your feet are separated, but when you lay down, that causes a drawing over of the top leg onto your bottom leg, which will cause an elongating or a stretch along those lateral tissues. So what you can be feeling, what your patient might be feeling, is actually those tissues being stressed by being kept in an overstretched position from her laying on her side all the time. All right, now what all of this is, I know it's not treatment, but it's giving you an idea of how to read what the tissues are telling you. You can identify what's going on in a person's daily life sometimes by what you read in the tissues. And that's the reason why I didn't have to ask her what side do you sleep on. Based off of what her tissues are telling me, I can see what side she sleeps on. If I couldn't see it before, if I got down here into her hips and pelvis, just feeling how one side it drops and one side is kind of elevated, I can actually feel that this side is used to being pried apart, which is similar to people who sleep on their side. Okay, we've talked about this before. Somebody has an approximated side in their low back, somebody has an elongated side on their low back. What do we want to do? We want to approximate the elongated and elongate the approximated. Which one do we do first? You deal with the approximated side. Why do we want to deal with the approximated side first? So that it balances out. Because we can't just make slack appear out of nowhere, right? We have to bring slack from somewhere. So if we try and approximate the elongated side before elongating the approximated side, we don't have as much slack to work with. All right, so the thing is though, Principles of Massage tells us you want to work on the unaffected side. Well, in this presentation, if she has an elongated one side and an approximated other side, which side will she complain of?
This one.
Are you sure?
Elongated.
Elongated,
Yes.
Are you sure?
You just said that she had felt
It depends.
it. Should have known that.
Now, somebody can be in this position because they sleep on their side. Yes, we know that. In which case, in her situation, my guess, it's not always 100%, my guess is it's the overstretched side because she's in an overstretched position, which can cause dysfunction on the other side. But an individual who drives for a living and they decide to sit like this all the time, they might be complaining about their approximated side that's bugging them. So Principles of Massage says that you need to treat the unaffected side, but regardless of what the Principles of Massage say, regardless of which side causes them pain, the approximated side or the elongated side, our goal is the same, to rebalance. It might be more uncomfortable for them if we start on the affected side, if that is the approximated side, but it will help us rebalance the overstretched side. Right? Remember, I'm not talking to you as an instructor right now, so I'm allowed to tell you to ignore Principles of Massage. You need that part.
Guest speaker.
Yes, I'm a guest speaker. I'm not one of your instructors today, okay? Okay, so with that in mind, we kind of have an idea of where the overstretch is happening, where the approximation is happening. So I'm going to go right into the middle, right into that epicenter, right? Good. So all I'm going to do, because my goal is to elongate the approximated side, I'm going to load in to try and challenge those tissues. Just get a nice breath in and out. When she breathes out, I'm going to start applying the shear with my bottom hand. Kind of, sort of. And as she keeps breathing, I start trying to separate the tissues. Sometimes you'll come across a patient who has a really hard time being able to just let go. What is another technique that we can apply that can encourage them to be able to disengage properly?
Breathing.
Breathing, yes. That's the neurofascial approach. But what if you're still having difficulty? Is there an active technique we can recruit? PNF style approach, correct. Okay, Jessica, I'll get you to very gently try and hike your hip up towards your shoulder. Hold right there for 5, 4, 3, 2, 1. Let go. Very good. Take a nice big breath in and out. Okay, let that go, let that go. Good. All right, once we work on this side a little bit, let's pretend we've worked enough to actually get those tissues to elongate a fair bit. I don't want to take up too much of your time, but now I've had more drop happening on that right side. In terms of approximating the elongated side, yes, we could just bow the tissues, but one thing that I really like to do, I don't have any linens here to be able to do that, but I usually actually just drag my patient over towards the side that I'm trying to approximate. Once I do that, I take our once stretched sacrum, lumbosacral junction, and I'm approximating that. And what I'm going to do is I'm going to further bow into that lumbosacral junction to try and further approximate those segments. Does that kind of make sense? Good. So through here, I'm not trying to spread like I was with the approximated side. I'm going to be trying to bow to try and approximate the elongated side. Nice breath in and out. Good. So this is me rebalancing through this segment of this chain. Okay, I'm kind of doing it bilaterally, but that's the way we like to do, try and keep the balance on both sides. So that's the lower portion. Let's say we magically rebalanced and she's all squared and balanced away on the table in the lower portion. After that, we go ahead and check to see what's going on in this upper portion. You might be able to see that this shoulder actually travels down easier than the side she sleeps on. Probably because she has a small pillow. Do you have a fairly thin pillow when you sleep on your side? Yeah, so that allows her head to actually drop towards the bed, and that will actually encourage her shoulder to be approximated, and that's the reason why she's more hiked and restricted on this side. So on this side here, the one that's hiked and elevated, and on this side here that's depressed, what areas need to let go? Let's start with this elevated side. What aspect of this shoulder girdle will need to let go to allow us to restore balance? The superior portion needs to let go to allow us to depress this. Now what about the side that depresses super easily? What area needs to let go to allow us to rebalance? The inferior aspect, because it's pinning it down. Does that make sense? Good. So then what I would do is I would work in this inferior aspect here to try and encourage things to drift upwards. Nice breath in and out. But the thing is, I'll still be engaging that lower half of the chain to try and encourage a lengthening through that entire segment. Okay, she's having a little trouble letting go. JT, I'll get you to go ahead and squeeze your arm towards your body. Hold right there for 5, 4, 3, 2, 1. Let go. Take a breath in and out. Let it drift. Let go of your shoulder. Very good. Good. So that's allowing that shoulder to come upwards a little bit, and then I'll spend a little bit of time quickly getting this to let go, and then we'll show you letting, rebalancing through the anterior chains, just so that you guys have a chance to practice. So from here, I'm going to engage the restriction. Go ahead, nice breath in and out. Drop your chest, drop your shoulder. Excellent. And my other hand is actually trying to elongate through those tissues down the lateral chain. Again, breath in. She definitely needs more work than this because I know she needs to be rebalanced through this upper C-spine. But that's okay. And let go of your chest. There you go. Good job. And breath in and out. Let go of your chest again. Perfect. Good job. So you'll notice in order to rebalance, I don't have to do that stuff is hard work, right? So instead, it's a lot easier to restore that communication between your patient's signals and their tissues. All right, JT, space up on the table, please. Good morning. Thanks. Thank you. And I left my rolly chair in the car. Dang it. Yeah, this one's better. Thank you. All right, so nice and briefly, we're going to go ahead and do the assessment that we did earlier with Nick. I'll get you to bring your arms straight up to the sky, please. Sky's up here. We're going to go off to the side. Nope, not down. Just off to the side. And you'll notice this one dropped later, right? So let's try that again, and just go ahead and drop it. Good. Yeah, drops later, and it wants to come down. Is that just you, or is it your tissues? Okay. So I'm definitely going to work through her inferior chain because they just keep wanting to be pulled down that way, right? So we'll go back up to the sky, and we're going to get straight back. Dang! She needs some work. All right, you go ahead and put this one back down. Good. Okay, so we're going to go ahead and rebalance through those lateral and horizontal chains. Nice and briefly first, I'm going to check to see how things feel. More balance in this upper portion. Good. All right, to start, I'm probably going to get in your way here. To start, I always like to start with just encouraging the shoulder to rest at neutral. Nice breath in. And soften and let go. Now the purpose of this reset is to encourage a full 360 reset in the shoulder. A lot of people have that one shoulder that's protracted forward, or both shoulders are protracted forward, right? So this, you can either come through here on the front just to encourage that to drop backwards with your neurofascial approach. Nice breath in. And out. And drop your chest. But one way I personally like doing this one is actually coming through here so that I can actually fully support the patient's arm with my arm. Nice breath in. And out. Encouraging through external rotation. I'm treating the shoulder three-dimensionally, one hand on the upper traps, one through the anterior chest. As she's coming out, I will further bring her into external rotation. Follow your shoulder. Good. Eventually, I'll get to a point where I can hopefully externally rotate to rest her hand on my shoulder. You are very tight. You need this.
Yeah. I also have several.
You have cervical ribs too? Oh. It's in?
Yeah.
Okay. So one thing you'll notice is whenever you're hanging out with the right instructors, you know they both have them too, right?
I know.
Okay, cool. We just
I'm
got
the
the
reason she got her X-ray.
Oh!
So
You
I
have
found
two?
out. Yeah.
Do you have two of them as well too?
This one's bigger.
Oh my god, we have 6 cervical ribs in this classroom that we know of, you guys. That is statistically anomalous. Alright, anyway, as I was saying. So when you go to externally rotate their arm, a lot of the times you will feel their upper traps grab as they try and actually help you put their arm back into external rotation. If you go too fast, you'll feel a grab, in which case you just back off, get them to breathe, so that when they breathe out, hopefully it's a fully passive motion of you externally rotating them and placing their arm on your shoulder. Okay? So from here, because we know that in order to fully address the shoulder, we need to address it in the full 180, 170, how many degrees of range of motion does it have? All of the degrees, in order to effectively treat the whole shoulder. So from here, we're treating through the internally rotated aspect of it. We're now bringing it into the external rotation. What I do here is I usually slide my hand underneath the inferior aspect of the scapula. But one thing to keep in mind is if their elbow is down here like this and you try and follow along the arm, very often people take like a ticklish cue and their arm might come in. So my suggestion is allow the arm to come up at least past 90 degrees, and that will make it a lot easier for you to be able to slot in to that inferior border of the scapula. Nice and breath in. And back out. I don't know if you can remember something I'm talking about, okay? Now that I know she has a certain rib. I mean, I did a full health history before treatment, right? Yeah.
Okay, you aren't our instructor. We can't
That's right, I'm not your instructor today. I'm just some other practitioner person.
You should take up the name tag.
What name tag? You're like, you're right. You're right.
We didn't see anything.
You will also find in active practice your patient will remember a history that's incredibly relevant about halfway through their treatment.
Yeah, that is one too. Oh yeah, I also broke 4 ribs 2 years ago. Does that matter? A little bit. Yeah, a little bit. Little bit. Nice breath in. Okay.
So right now, only just calling it out.
Not even. I'm just engaging where I can feel the tissues are like holding on. I'm engaging them and I'm cueing her to breathe. Yeah. There you go. Nice breath in. Drop your chest, drop your shoulder. Now, when you're in this position, you're in the inferior aspect of the axilla and grabbing into the inferior aspect of the scapula, or into the upper traps. Everybody is going to be more tight in one of them. For her, it's her lats. She is very tight in her lats. So from there, that's where we're going to be focusing on. If they're more tight into the upper traps, that's when I would focus on the upper trap component. But for individuals who are more tight in their lats, that's when I focus on the lat component. So when I'm in this position, because I'm going to focus on the lat component, nice breath in, and out. I am going to focus on trying to lengthen through this lateral chain, okay? So to try and disengage through this lateral chain, I'll try and bring her up to challenge through these lateral structures, and this is when you guys usually see me do that weird twisting external rotation stretch thing that I do with this anterior aspect, trying to stretch through this chain here. So I can challenge through the pecs if I wanted to, and through that anterior diagonal chain, or I can challenge through the lats, through this lateral chain. Nice breath in. Okay, and she real tight, so I'm going to incorporate some PNF. Jessica, I'll get you to go ahead and bring your elbow down to your side. Hold right there for 5, 4, 3, 2, 1. Let go, breath in. And out. Excellent. And again, go ahead, try and pull your elbow down to your side. Hold for 5, 4, 3, 2, 1. Let go. Breath in and out. Good job. You okay?
Her scalp too.
Good. Sorry? I was not. You can pin that down actually if you wanted to just work on that aspect of the chain. Now that's a really good point. Thank you for bringing that up. Go ahead and finish your question.
Oh, I thought you would just pull like both of them down.
No, I was actually, well, I mean, like, you can, but it depends on where you feel the restriction. Most of her restriction is right here, so I kind of want to pin down just below that and focus on that spot. Yeah, so and that's the thing. You can actually challenge through the segment, which is what I was doing, where I was landmarking here, and where I landmark here essentially stops the rest of the chain from being engaged. Right, so I can actually target this area here. But if I wanted to target the full chain, I don't have to anchor there because I can actually just target through the full chain. But if I wanted to make it more specific, that's when I can actually landmark and pin down